Morning, everybody. Thank you so much for inviting me. I can say that I'm really impressed with the conference so far, and I can see all the advances happening in the cholangiocarcinoma field. Hopefully, our study can contribute something to it, and we can progress in the earlier diagnosis of tumors like cholangiocarcinoma. So I'm going to talk about something different, something that some of you haven't heard before. It's a breath test that can diagnose cancers of the gastrointestinal tract. Our aim is to develop a test that is not invasive and can diagnose a cancer in seconds. We know the burden of gastrointestinal cancers is increasing the last few years, and the earlier diagnosis is of crucial importance. We know, especially for cancers like liver, pancreas, biliary tract, patients present in the hospitals at a later stage. This has led to decrease net survival, 5-year net survival, and the net survival at the moment for liver cancer is 13%. There's an increasing and unmet clinical need to develop this test because there are symptoms that surge between patients with benign disease that leads to delay of diagnosis and, unfortunately, a poor survival rate. What are we planning to do? We're planning to have a test that all patients with non-specific abdominal symptoms will go to their GP, provide the breath, and depending on the results, we can direct them to the exact test they need. Either this is a CT, an MRI, a camera test, or just reassure that their test is negative and they don't need further testing. How can we do this? I have a video that I can show you later, but you can see in the screen, this is our breath device, which is nothing else than a breath pump. This is our breath bag. As you can see here, there are some small metallic tubes, and then we're running through a specific device, and we know what are the molecules in your breath and how these correlate with specific types of cancer. And this leads to my study. This is a study to develop a breath test using volatile organic compounds, which are byproducts of our normal metabolism, for monitoring of cirrhosis and detecting primary liver cancers like cholangiocarcinoma and hepatocellular carcinoma. Our previous study so far showed that for hepatocellular carcinoma, the area under the curve, which is how good we can detect, is at 94%. That was done by one of my colleagues in the past who ran the VOCAL-1 study. After we had successful results for most of our tumors, and the HANA group has run studies on gastric cancer, esophageal cancer, and a lot of them are published in big journals, and all of you can have access to them. We can see that the sensitivity and the specificity of this test is high. So the research is very promising. As I said, the liver cancer is the 6th most common cancer globally. And unfortunately, due to the non-specific symptoms or due to the late presentation of patients in the hospital, we have late diagnosis and nearly 13% of 5-year net survival. Therefore, we know we need this test. We need to detect these cancers early. It is a test that is non-invasive. We've run multiple series of focus groups, patient and public involvement to decide this is the right test for the public. How does this test work? The volatile organic compounds are normal substances that run in our blood. And we know through the blood goes through our lung, and these molecules are excreted through our breath. So with our test, we are able to detect these molecules running through our devices, and we know that there are specific molecules for specific type of cancers that can predict the evidence. And that's the VOCAL-1 study, the study that was done before me. And we want to know if it is successful, and if it can work. As you can see, it started in 2019, and it finished in 2021. I'm pretty sure you all remember that this time of the year we had COVID-19. And unfortunately, they didn't manage to include as many patients as they wanted. And that study included only hepatocellular carcinoma, not liver cancer. After a lot of discussion with patients, we found out that we need to add cholangiocarcinoma there. There is need for it. And this led us to the VOCAL-2 study. It's a study with 3 arms. The first arm is patients with liver cancer, and this includes hepatocellular carcinoma and cholangiocarcinoma. The second arm is 250 patients with cirrhosis, any type of cirrhosis, alcoholic, or patients who had viral hepatitis that progressed to cirrhosis, or patients with primary sclerosing cholangitis. And the third arm are patients with normal livers, but non-specific abdominal symptoms. We're going to recruit 750 patients in total, and I'm really pleased to say we are nearly 2/3 of the recruitment. So I have recruited 501 patients to date so far, with their challenges, of course, but I'm nearly there. So, of course, these tests go through a robust quality assessment, and if we see that some of the samples are not adequate, they'll have to be rejected. That's why you can see that we need 80% of these tests to be 100% past the quality assessment. Our inclusion criteria, because I know I had a great interest from a lot of groups. This is the test we're trying to develop, is a test that is going to target people with an unconfirmed diagnosis. And my target through this study is to develop a model that can predict this cancer, to diagnose these cancers. So we include adult patients with a histologically or radiologically confirmed hepatocellular carcinoma or cholangiocarcinoma. Patient with liver cirrhosis, again with a confirmed diagnosis. Patient with primary sclerosing cholangitis with confirmed diagnosis. And patients that have non-specific gastrointestinal symptoms, such as abdominal pain, some nausea, vomiting. But they had some imaging within the last year that shows a normal liver. And most of us that are clinicians, we know that the normal liver needs to say that's a normal contour echo texture. If someone has a fatty liver disease or there is a cyst, unfortunately I have to exclude them. Our exclusion criteria is an active infection within 8 weeks, or if any of the patients are receiving immunosuppressive medications like steroids or monoclonal antibodies. We've run previous studies that shows that these medications actually change the profile of the volatile organic compounds. That's why we exclude them at this stage. History of another cancer within the last 5 years, previous liver resection, previous treatment for their cancer, such as radiotherapy, chemotherapy, or immunotherapy. Pregnant women, comorbidities affecting the breath collection. Fortunately, I didn't have anybody who couldn't breathe at the hospital, so I'm lucky. And patients who are unable to provide an informed written consent. What is our target? Our target is to develop a model that is able to diagnose in details liver cancer. Either this is a cholangiocarcinoma or a hepatocellular carcinoma. By diagnosing and detecting it early, will lead them to treatment or the specific test quicker, rather than waiting through the referral pathway for weeks and weeks. And the final test of the group is to develop a pan-gastrointestinal cancer breath test. And we ran a big study of 8,000 patients now amongst the HANA group, that we include all the patients with non-specific gastrointestinal syndrome within the 2-week wait pathway. So the target is, you can go to your GP, provide a breath test, and we'll be able to say, don't worry, everything is fine, or yes, we have specific concern that this may be cholangiocarcinoma. Please, you need to see a HPB surgeon and have this specific investigation. At the moment, we have 12 active sites and 3 more are joining shortly. You can see we have expanded our recruitment across the UK, and very soon we're opening in Wales as well. And I will show you a very quick video how quick is the breath test for the patients themselves. It's literally, at the moment, 1 breath.
In this video tutorial, we will be demonstrating how to collect a breath sample from a participant taking part in our research. First, make sure you have all the required equipment: a gas sampling pump, sample collection bags, thermal desorption or TD tubes and their accompanying long-term storage caps, a set of cap lock tools, and powder-free disposable nitrile gloves. Before starting sampling, ensure the participant is eligible and has provided informed consent as per the study protocol. Always wear powder-free nitrile gloves before handling the gas sampling pump. Turn on the pump by pressing the switch on the back, making sure that the pump is also plugged in. Press Enter to proceed. Note down the device ID and file number displayed on the screen and record them on the study forms. Do not connect any TD tubes yet. Press the play button to start the purging cycle. Confirm that tube 1 and tube 2, T1 and T2 flow rates are at least 200 mL per minute. If not, stop and contact your study's trial manager or named contact for support. Each breath sample is collected onto 2 TD tubes. Use the set of cap lock tools to loosen the storage caps on both ends of the first pair of tubes. Once both sets of storage caps are loosened, remove the caps from each end by sliding them off and immediately insert each TD tube, one at a time, into the white particulate filter, aligning the arrows so that they are pointing towards the pump. Check the disposable sample collection bag to ensure it is clean and the ports and caps are intact. Remove the plastic caps from the bag's tube ports and firmly attach the bag to the TD tubes using the ports. Avoid touching the very ends of the TD tubes to prevent contamination. Explain the breath collection procedure to the participant before starting. Have the participant exhale into the bag until full, feeling slight resistance. Multiple breaths are allowed, but if possible, a single full breath is preferred.
And that was a breath test for the patient. The only thing they had to do is breathe out. There are a lot of technical information in the video, but when this test is readily available, the patient, the only thing that they have to do is come in, breathe out, and wait for the results. Thank you very much, and I'm very happy to receive questions.